Hello and welcome everyone to the EAO session, Just Ask. Again, with the beginning of the month, it's the first Monday of this month, and we're here again with our Just Ask. Tonight with a very, very, very interesting topic. It's just cutting edge topic. And I already see that a lot of people are logging in from different countries all around the world. Already also from countries which have it much more warmer than we have it. We have also Björn here from Sweden. Hi Björn, great that you are here. So just log in, type in where you're from, type in what you do, and also if you have questions, type them in and I will hand it over to our expert. And there we are, right in the scene. We have a top-notch expert tonight. We have Nicole Winitsky today from Sweden. And Nicole, it's not only a pleasure for me to host that show, it's also, I have to say, you're from my favorite country. Sweden is such a nice country and I love it. When I traveled there, I love all the people. And that's very, very special for a German. I drive a Swedish car. So welcome, Nicole Winitsky, to the show.
Thank you so much, Stefan. I'm so delighted to be here, and I'm so delighted that you like Sweden. I also like Sweden.
I do. It's a great country, and we love it there. We love to travel there, and very, very nice people. So please log in and type in your question. We have already Turker there logging in. Nicole, maybe just a few words to your person. And I think I will start with one thing immediately. You just finished your PhD some month ago, and I would love to congratulate you for that because I know what kind of hard work it is. So congratulations to that. And you will also speak about your work, your research, which is really impressive. Even more, you are a prosthodontist. So tonight it's a periodontist, which is me. And a prosthodontist. I wouldn't say it's against, but let's see. Maybe we have different points to your topic. You are a researcher at the Eastman School in Stockholm. You also work at the Karolinska University. You also are, of course, a practitioner. Your field is anterior implants, is aesthetic implants. And you lecture worldwide. You just came back from Singapore, I guess. That's when we briefly met last week. And you host a very, very nice podcast, which I don't know how to pronounce it. It sounds like blood something. I don't know. I don't know. I don't hope it's about blood all the time. But again, a very, very warm welcome to you. And we're very happy to have you here.
Thank you so much, Stefan. Really.
So tonight, the topic is a very distinct topic, and probably a lot of you have seen that over the years, is that suddenly implants change positions, or do the teeth change positions? And we see different infra-positionings, we see opening of abrasure spaces, and that's what we would like to discuss with you tonight, because you are the true expert. And I would like to show you a case, Nicole, which came across me actually last week. I knew I'm going to have you, an expert in that field, and look at that case. It's an anterior implant. It's a single implant, tooth number 8 or tooth number 11, and looks nice, looks good. And 8 years later, I suddenly have a step, which is not huge, but it's there. Let's be clear. And that's your topic. So what do you think about that case? Just in a nutshell, is that infra-positioning or is that super eruption of the adjacent teeth? What would you say?
Can I first ask how old the patient is?
The patient is in her 50s.
50s. And yeah, and that's very interesting. Well, I have been reading and studying and writing about this parallel to treating these patients and also following them over time. And from what I have been reading, it is a matter of the adjacent teeth moving as the craniofacial growth continues throughout life, which is what I'm also going to talk about. And also that the teeth continue to erupt a little bit more. So these changes makes the implant end up in another position than the teeth, because it doesn't have the same possibilities as the teeth have.
Yeah.
To follow the growth.
Sounds great. I'm thrilled, and I want to know about this. Already we have much more people logging in. We have Alfonso logging in. We have Eva logging in. We have Jose logging in. We have Halun logging in. So a lot of people want to know about infra-position of anterior implants. And Nicole, I know you have prepared a short presentation, and I would love to see that presentation. Please start the presentation, and we would love to see your research and also your clinical application with that, please.
Thank you so much. Okay, so I would like to start by showing you this clinical case of mine. This is a patient. Her name is Johanna. Johanna's mother is Swedish and her dad is Irish. And on her dad's side, there are quite a few other family members that are missing teeth, and so is Johanna. So she is suffering from aplasias of her upper laterals and all her upper premolars. So this picture is taken just after she has received her single implants in her upper lateral, both left and right position. And this is a close-up picture of Johanna just a week after the delivery of the crowns. And before saying anything else about this picture, it can't be stretched enough how important it is with a good teamwork to be able to receive good results with these patients. So in this case, we have an orthodontist, an implant surgeon, and also a dental technician whose efforts is really, really important to receive a good result. So Johanna was treated here at the Eastman Dental Institute, which is also where I work. And this institute was funded by George Eastman, and it was built between the years of 1932 and 1935. And on this sign that is placed in the entrance of the building, it says that this building has been built to benefit generations to come, meaning that George Eastman understood how important it was for children and young adults to have good teeth to be able to live a good life. So for many years, there was a department in the lower right corner of this building called the Department of Juvenile Prosthodontics. And this is where all the children and young adults in the greater Stockholm area had their teeth replaced or changed if you needed any kind of prosthodontic treatment. And this is also the department where a woman called Kerstin Olgert worked. And she gathered the first 42 single implant patients according to a strict protocol. All patients were treated by one prosthodontist, one surgeon, and one radiologist. And these are the patients that I had the opportunity to use during my research. And this is the material that I'm going to talk to you about today. Just as of for now, the Eastman Institute is since 2016 a specialist center where we today treat both children and adults. So we'll leave Johanna for now, and I'm going to come back to Johanna later on, and we'll move a little bit more into the theory. So I would like to start to talk about the differences between a tooth and an implant. And all of us here probably are working with implants, and we know that there are several great differences. But one difference that has been shown to be very important for my research is the presence of a periodontal membrane. Because the periodontal membrane that exists around the tooth has several important functions. Well, one of them is that it gives the tooth the possibility to adapt to the continued changes occurring in the face and within the teeth all throughout life. While around the implants, we lack the periodontal membrane, and therefore the movement will look different from an implant in relation to a tooth. So today, single implants is a very frequently used treatment modality in young adults. And this is because the alternative of the 3-unit bridges requires that we need to prepare the adjacent teeth, which is something that we really don't want to do, especially in young patients with intact and beautiful teeth. But there are actually also options that we can use that does not involve grinding of the teeth. One of them is orthodontic space closure. We can also use the option of autotransplantation. And we can also use the option of resin-bonded bridges. And I think that all these options should be considered when we treatment plan these patients. So I want to take you a little bit back and start with the history of the single implants. The first single implant was placed in 1982. But weirdly enough, not until 1989, the method was actually fully developed to make a crown also on top of the implant. And at this time, there was mainly adults that was treated. The studies that was published at this time talked about up to 45% of the implant crowns becoming loose due to the derotation of the screw inside the crown. In just 3 years, 45% of the crowns became loose. But this changed with the 01 single tooth abutment that came to the market in 1992. That gave us the possibility to make a crown that did not become loose to the same extent. And it also gave us the possibility to make crowns that were more aesthetically pleasing than the previous ones were. So in Gothenburg, which is on the west coast of Sweden, a lot of research around the implants has been made. And in 1994, Birgit Tillander started to make studies where there were actually implants placed in adolescent patients. And in 1996-97, the head of the Department of the Juvenile Prosthodontics, Kerstin Olgart, she started this study which she collected the first 42 young adult patients treated with the 01 concept. And I will be forever grateful for Kerstin for doing this, since this is now the material that I had been able to do a 17-year follow-up study on. So what we do know from before is that we know single implants end up in infra-position due to the continued changes of the face. We also know that the main changes occurs in the lower part of the anterior face. We also know that the physiological hard tissue remodeling and the soft tissue changes that are occurring are expected in the face all throughout life.
Nicole, okay, can I have a quick question?
Yes.
You're saying, which is interesting, which I didn't know, that the main changes that occur in the lower part, meaning starting from the nose, let's put it like this.
Yeah.
Do we know if it makes a difference in the upper jaw or in the lower jaw? Are there differences?
We do know that the greatest changes occur in the anterior area of the maxilla. Mm-hmm. That's where we see the greatest changes. Yeah. It's a little bit funny with this material that I've been working on, because it is, now I'm not showing you the whole part, but it's a lot of orthodontics also involved in this in these studies. And orthodontics is not actually my specialty area, but I've had to learn quite a lot about orthodontics, and talking about these things and changes that are occurring in the face. We don't really talk that much about that in prosthodontics. Sure. While in orthodontics, there is always discussions about how much the face is changing and which part of the face that's changing. And
how much relapse that makes, sure.
Yeah. Exactly, mm-hmm. Exactly. So I think that
it could also, is that what you're saying? It could also make a difference if that patient was pre-treated orthodontically or if he was not.
I'm going to tell you that right now.
Great.
Okay, so let's move on. The material that was treated in these studies, it consisted of 42 patients. They were all missing teeth in the anterior maxilla, and they were 24 men and 18 women. And in total, they have 53 single implants, which means that they have between 1 and 3 implants per patient. The mean age of the patients was 21 years, and the main reasons for tooth loss was trauma or aplasia. And they were all treated with the Brånemark implant with the machine surface. On top of this, there was a CER1 abutment placed and an alumina crown cemented on top. And the delivery of the prosthetic reconstructions was between 1996 and 97. So I want to just talk a little bit also about the survival of the implants in this study, because what we found was that 2 implants were lost during these 17 years in 2 different patients. One after 3.5 years and one after 11 years. And if we look at the survival of the crowns, we found that 10 crowns were lost in 6 different patients, while 6 of those were in 4 patients that were lost due to trauma, and 4 of them were in 2 patients that were lost due to aesthetics and infra-position. So the survival in this group of patients after 14 to 20 years showed a 96% implant survival and an 80% crown survival. So let's move on to the topic of the evening, infra-position, which is where I'm also going to dig a bit deeper into the study that was published by me and my research colleagues in 2021 regarding the 3-dimensional tooth movement of the teeth adjacent to the implants. So what is happening why the implants end up in infra-position is because the maxilla moves a little bit downwards, and the anterior teeth also moves inferior and posterior, which makes the implant that does not move to end up in a position where it becomes shorter and a bit more buccally tilted most of the time. So if we look at this can be measured in different parts of the crowns. We can measure it incisally. We can also see these differences cervically, and we can also see it by the tilting of the implant.
Nicole, why do we see the tilting?
Why we see the tilting? Because it's actually not all the patients that show, in my material, it's not all the patients that shows a buccal position, but the natural movement of the maxilla and the teeth is inferior and posterior.
Posterior.
And since the implant is not moving, it stays in the original position and it ends up in a more buccally tilted position. And this is also why we a lot of times see that we end up with thinner buccal tissue to the implant with time.
But what would you say? I mean, you probably didn't do any 3-dimensional radiographs, right? Just to evaluate it. Do you also think they're going to lose bone on the implant because the whole maxilla sort of moves posterior? Understand what I mean?
Yeah.
So it sort of digs bone also from the implant. Can you imagine what I think?
I think that that the tissue is changing, and I think that it becomes thinner with time, buccal to the implant. I have not done those measurements, but I so want to do those measurements, which could be done in this material. And I really hope that I will be able to do that in the future, because it would be really interesting to measure what is actually happening.
Right.
Because what we have here is that we have the study models that Kerstin Olgat took at baseline. And I then made new study models at the 14 to 20 year follow-up. And we could then compare the 2 models with each other, which is how we made these measurements. So we scanned the models and we placed them into software. And in the software, we could superimpose the models on top of each other. And by using the implant as the steady reference, we could then measure the movement of the teeth adjacent to the implants. So what we did was that we decided to use the tooth mesial to the implant, and we could, in this software, measure the mesiodistal movements, the buccopalatal movements, and also the incisal movements of the adjacent teeth. You can see here in this picture, the yellow dotted area, that is the movement of the upper left one during this 17-year follow-up.
But Nicole, in that picture, if you go back one more time, I think it's very interesting. You really see that the implant does not move at all. Is that true?
I think so. That's from what I've been reading, and we've been discussing this in my research group. I think that the implant is not moving, but
Which
I
is
think
interesting because we talked about that before the show. We see opening of embrasure space between two implants, right? Sometimes.
Yeah, we do. But we also see here, we can discuss this more when I showed you the results of this, because we see that there are movements occurring in all three different directions.
Okay.
But what we also wanted to do was that we wanted to identify patient and implant characteristics, because we wanted to see if some of these characteristics could show us which patients will have more severe infraposition than the others. So the characteristics that we used was the facial type. So we categorized the patients into long, neutral, and short facial types. We also used the measurement of the lower anterior facial height, since this is the area that we know that the main changes occur in. And we divided the material into two different groups, where one of them had a lower anterior facial height of more than 70 millimeters and one of less than 70 millimeters. We also looked if the age at crown delivery would make a difference. We also looked if the sex of the patient made a difference. We also looked if the implant position, if it was placed in an incisor, lateral, or canine position, would make a difference. We also looked if the cause of tooth loss, which was trauma or aplasia, would be different. And as you asked before, we also looked if pre-prosthetic orthodontic treatment was a factor that would make a difference in the amount of infraposition. So what we also did was that we wanted to find out if the patient thinks that this is a problem when the infraposition occurs. So the way we did this was by using the visual analog scale. So we asked the patient and the operator the same question, which was, how satisfied are you with the aesthetics of your or the patient's implant crown? And then we plotted this into the scale from 0 to 100, where 0 means not satisfied at all, and 100 means fully satisfied. So what did we find? Well, when we looked at this group of infraposition, we had, of course, to remove the patient that did not have the original crown left. So now we had 32 patients, and the mean age of this group was 21 years, and the mean follow-up time was 17 years. So we found, when we looked at the movement in all three different directions, that it ranged from 0.02 to 2.5 millimeter in movement. And the 0.02, of course, is very, very small movements. When we look at these pictures, it's just one of the patients picked out of the material. When we compare the baseline picture to the 14 to 20-year follow-up, we can see with our eyes that there is a difference here. You were talking about opening contacts. We can see how the upper right one has become shorter, especially in relation to the lateral, I think. But if we look at the numbers here of the measured movement, it was an 0.01 millimeter distal movement, together with an 0.5 millimeter buccal movement and an 0.4 millimeter incisal movements. So these measurements come out really, really small, even though we can actually see that something has changed. But we wanted also to find a measurement that we thought was a more clinically relevant measurement. So we picked the 1 millimeter movement, and we looked at all patients with a movement of more than 1 millimeter. And we found that 30% of this material had a movement of more than 1 millimeter. If we only looked at the incisal movement, we found a mean movement of 1 millimeter to a rate of 0.05 millimeter per year. So that's the rate of movement. When we compared the different teeth to each other, we found that the teeth that was placed adjacent to an implant in central incisor position, we had a mean movement of 0.5 millimeters, while when the teeth was adjacent to implants in lateral incisor or canine position, we found a mean movement of 1 millimeter. So, what did the statistical evaluation show? Well, it showed us that despite that we now know that all implants end up in some kind of infra-position, despite this, 63% of the patients rated the aesthetics of their crowns as more than 80% of the base scale. While looking at the dental assessments, only 20% of the crowns were rated and scored to more than 80%. So to conclude this, 100% of the implants end up in infra-position after 14 to 20 years. Lateral and canine implants seem to end up in greater infra-position than central incisor ones. We also found that the greater the vertical changes was, the more buccal tilting occurred. And also, despite the 100% of infra-position, the majority of the patients were actually pleased with the aesthetics. And as in so many other studies, also this study showed that the patients are more satisfied with the aesthetic result than the dentist. So what about the patient characteristics and the predictors? In previous studies, there has been written quite a lot about age, sex, and facial type to be factors that we should use as predictors. We could not find them to be reliable predictors in this material. What we did find was, however, that less tooth movement occurred if the lower anterior facial height was less than 70 millimeters, if trauma was the cause of tooth loss, and if the implants were placed in central incisor position. So, do you remember Johanna? We didn't forget about her. Here she is at the delivery of her implants. And this is the close-up clinical picture. And not too long ago, I saw Johanna for a 7-year follow-up. This is about the same range as with your patient. She's now 26 years old. She's still very pleased with her implants, and I also think they're still quite okay. But if we look a little bit closer and compare these pictures with the baseline picture and the 7-year follow-up, if we start to look cervically, we can see that the differences between the incisors and the laterals have decreased. And if we look incisally, we can see how the differences between the central incisors and the laterals have increased. And I must remind you now that Johanna is 26 years old. She's had these implants for 7 years. She's going to be able to use these for many, many more years. And I am really curious to how she's going to look in the future. And I'm going to continue to follow her and see how this is going to develop. But already now we can see that changes are starting to happen.
Nicole,
so
I have a quick question for you. When I look at the case, you've been talking about eruption of the whole maxilla. I think these are two different things, right? Eruption of the teeth out of the maxilla and eruption of the whole maxilla. So does both of them occur? Or what do you think?
Yes.
What happens?
Both of them occur.
Sometimes I have the feeling when I look at Johanna, it may rather be eruption of the teeth, right? Because we see changes in the gums already, right?
But both things occur. And this is something that has been studied in many studies, in orthodontic studies. They've been looking at how the facial skeleton is changing over time. And this has been studied both in younger groups of patients and also in older groups of patients. And there are atlases describing all throughout a person's life how the face are changing. But the faces are changing in different ways, depending on what kind of facial shape you have and what kind of angles you have. And this is where I think that we need to learn more, because I think it would be great if we could predict which patients that we will see that have more severe infrapositions than others.
And can we?
And can we? Yeah, that's the question. I'm going to conclude now, and then we can discuss if we can predict infraposition or not. So I want us to be able to use the scientific results for clinical applications. And my clinical applications from these results would be that I think we should be aware of that the main part of our patients with single anterior maxillary implants will show infraposition in a long-term basis. That is going to happen. But unfortunately, today's knowledge is not really enough for us to be able to say that we can predict the magnitude of infraposition for the individual patients. We have a few leads within the results of these studies, but they will need to be confirmed in other studies and need to be studied more in different ways, I think, for us to be able to really use them. But if these 70 millimeters would be able to use, it would be fantastic, because then it's a really simple measurement that we could do. Then we measure the lower anterior facial height from underneath the nose to underneath the chin. And if that could help us to predict if the patient is in great risk of infraposition or smaller risk of infraposition, it would be very useful. But I don't really think that we are there today.
Do you think that the age makes a difference, like only because of time, or is also the speed of the change of the maxilla and the mandible different at different points of age? You understand my point?
Yeah, that is a very, very good question. And it is actually both. Studies have been made where they have compared younger patients that are between 25 and 35. And they have compared it to another group of patients that between 45 and 55. And they see that the younger group of patients have a faster development. So things are occurring faster when you're younger, but it's also in combination with that it's occurring over time. There is another study that has been made by Torsten Jämt in Sweden, where they have done I have done my study according to the same parameters. We've been trying to look at the same things in my material, which is a younger group of patients, and compare it to the patient material where the mean age is 37 years. And it actually turns out that these 30%, that we found 30% that have an infraposition of more than 1 millimeter. And in the material of the older patients, they had 35% with more infraposition than 1 millimeter. So it's very, very close. Yeah. So I think that we might be able to say that probably 30% of our patients will receive an infraposition of more than 1 millimeters.
Okay.
But then we want to know who these 30% are. But I think something else that we should be aware of, at least in this material, that although infraposition occurs, the main part of the patients doesn't think that the infraposition has a great aesthetic impact. So we should be careful so that we don't make a bigger problem out of something that might not be a big problem for the patients. So my recommendations would be that I think we should inform all patients that we plan for single anterior maxillary implants about the risk for infraposition. I think that we should try to postpone this treatment modality for as long as possible. And I also think that we should screw retain all the single implant crowns, because I tell all my young patients that needed implants that they will probably have to repair or replace or do something with their implant crown at least once, maybe even a few times during lifetime. So if we screw retain the single implant crowns, it will be much easier for us to be able to do these changes, and also for the patient. So I do, however, want to say, when talking about the long-term survival on single anterior maxillary implant, that with numbers of 96% of implant survival and 80% of crown survival, that we have a really good survival rate on this kind of treatment in this young patient group. So with that, I would like to thank you so much for listening to my lecture, and I'm so eager to hear if there are any more interesting questions, and thank you for your questions, Stefan. Really great.
Nicole, it was amazing. It's such an interesting topic, and congratulations to your work. That's such a good piece of research, which was definitely needed, because I guess there's not a comparable research to that, right? At least 17 years. I don't see where it should be. So thank you very much. Congratulations. People applaud you to your lecture in your chat. And besides my annoying questions, there are already some other questions which I would love to hand over to you if you are still willing to hear some question. Sven, actually, hi Sven. Sven Mühlemann had a question which I didn't get completely. Sven, maybe you can allude a little bit to that question. He asks that in some cases he sees that the neighboring teeth are holded back by the implant, and he sees sort of an open bite. Do you get his point?
Yes, 100%.
Perfect, Sven. Don't say anything.
I'm totally with
you, Please.
Because what we have been doing in this study, because since we choose the implant as a reference, all that we have been looking at is the differences between the implant and the adjacent teeth. But when I look at these patients, I see that, I think that's what Sven is saying, that like the whole segment is arresting in its growth a little bit. So this is also something that I would like to continue to do with this material, and choose a greater part of the models as a reference to be able to see what is happening on a bigger area. But I think that there is some kind of arrest in the whole bony area around the implant in some way. Because
the implant is like an anchor. And by this are also holding back the neighboring parts.
Yeah.
Is that what you see?
Yeah,
or
like when you have an ankylotic tooth, you can also see that like the whole area with the adjacent teeth, that you get, like Sven is saying, you get a little bit like an open bite.
But the total reason for it, Sven asks if you have a reason for it.
No, I can't really explain the mechanics around that.
We have also one more question from Alfonso. Hi, Alfonso. Thanks for the question. I think it's a very, very good question, a little bit philosophical. He asks you, if you now know what is happening, you don't know it by numbers, but you will know what's going to happen, for example, in your HANA or whatever. Would you change the position of the implant accordingly to the knowledge what's going to happen in 10, 20 years? It's a little bit philosophical question, but I think it's a good question. Yeah, really. No, I've been thinking about that also. And if it turns out that in a long time we have an implant that is placed too buccally, we talked about that a little bit before also, Stefan, because what we see when this happens is also that the buccal tissue, both maybe the soft tissue and the bone, seems to become thinner with time. And we don't want the implant to be ending up so buccally, which we actually do sometimes, so that we can see the implant shine through. So maybe it would be a good idea in these young patients to place the implant a little bit more palatally, to have some space for these changes to occur. So that would be one more reason to place an implant as palatal as possible, in particular in a young adult, right? Yeah, definitely. In particular, if I see your research, if it's lateral incisors. Exactly. Laterals and canines. I learned something.
You did. Very good.
No, it's great work. We have a very nice question, which I think it's very useful to answer that. It's not so much depending on your research, but still, I think you can give us your judgment. At what age do you recommend putting implants in cases of missing laterals or avulsion of kids, teenager teeth, or aplasia? Difficult question, but still give us your clinical take. I mean, you already said you're gonna sort of move it to a later age, but what is your take? What would be the earliest?
I don't really like to talk about ages. I think that we should look at every individual patient and see what kind of patient this is. It depends on so much. It depends on the space you have. It depends on the volume of bone that you have. It depends on if the patient is good with oral hygiene, if the patient is a smoker. But maybe the biggest thing, I think, is the smile line. Because if you have a high smile line, and if you're 20 years and you get an implant and you get quite severe infra-position in 15 years time and you have a high smile line, you will be 35 years old and you will have an implant that looks horrible. Some of these pictures, some of these patients, it doesn't look nice at all. So if you have a high smile line, it will be really disturbing and it will be a really big problem for us to do something about it. While if you have a low smile line, maybe it doesn't matter if the cervical lines don't match, and then we can make the patient a new crown after 15 years, and they can continue to be happy with their implant. So I am very careful with treating patients up until 20, as long as possible for the patients with the high smile line and with these. They usually come in combination also with the longer faces.
Yeah, in particular, I think because we have good alternatives, right? I mean, why not use some adhesive dentistry, Maryland bonded bridges, whatever, to sort of push the age to 30 something, and then we want something in these cases. Yeah. This is what
and the full ceramic resin bonded bridges that we can do today, they are so beautiful.
Yeah,
they really, and they seem to work well. There's both 5 and 10 year follow-ups now that show really good results, actually comparable to the survival of single implants.
Nicole, I have one more question, maybe the second last one. I was interested by the orthodontic pre-treatment. We sort of lost that a little bit because we wanted to talk about that a little bit. Do you think like an orthodontic pre-treatment, I think I saw your results, but does that change the speed of the relapse, or does it change the growth, or whatever? What is your take? So should I be more careful in patients which are pre-treated orthodontically when I look into infra-positioning of my implants over the years?
I also thought that we should get those kind of results, but we couldn't find that. Of course, this is not a huge material, and maybe if we had a bigger material, we would have found some statistical significance with that parameter also. But we didn't here. But what we always need to be careful with is whenever we have patients that have been treated pre-prosthetically with orthodontics, we need to have really good retention.
Yeah.
And because if we don't, and if we get a relapse of the orthodontic treatment, we will have even greater changes occurring.
Yeah, and it's sometimes hard to predict. I remember a case where I extruded a canine, extruded it 2 or 3 millimeters because of deep decay. Nothing happened over 5-7 years, and suddenly a patient came to my office, and the canine was back in the housing it was in the very beginning. So interesting, right? It's just so hard to predict.
It is. It's really, really hard.
So
I also had a patient who I actually made resin bonded bridges on her. She had them for 6 years, and she was using her retention. It was a removable S6 retainer. And she was using it for 6 years. Everything looked great. then she went to her general dentist and had an occlusal filling. And then the Essex retainer didn't fit anymore. And in 2 weeks, the canine started to rotate and the resin bonded bridge with that. So retention is needed also all throughout life because changes are occurring.
Yeah. Very interesting. We have people applauding you. Alfonso is saying, brilliant work. We see excellent lecture. Congratulations. Astonishing results, which is, I think, also a very, very good saying. We have Björn Klinge telling us he wants to see Johanna when she turns 70.
Yes, so do I.
So we have Nicole back here in some years down the road. So very nice. I just have one very last question, and I hope I'm not starting to annoy you now, Nicole.
No.
If we see all these changes around the teeth, and you can also say, I don't know why this happens. And I will have to come back to my question from the very beginning. Why do we see changes between two implants? How can that happen?
I don't have a good answer to that, but I have also seen that. I had a patient like that with implant in both the upper laterals and upper canines. And I have a picture that I made the picture for a lecture and I was showing how important that is to floss in between. So I have a picture showing the dental floss, which is really tight. And then 2 years after, I have a new picture where there is an opening of, I can't say how much, but a very clear opening. And I can't explain that, but there must be things going on in the bone in this area, even around the implants. It's like everything else, it's multifactorial.
So are you saying there are some things between heaven and earth which we don't know?
Exactly. But we need to find out.
I think that was a very, very good ending of this session. Nicole, everyone is applauding you. Please look in the chat later. Everyone is saying beautiful, wonderful, great.
Thank you so much.
And I can totally agree. It was a great presentation. It opened my mind. I learned a lot. Central incisors are not so much a problem with infra-position. Lateral and canine are. Look for that, Stefan. And with this, I would like to thank you for your time. It was amazing to have you. Just maybe two more things. The abstract submission for the Milan EAO annual meeting is just opening. So for all the researchers around the world, Nicole, you already also did an abstract, I think, in the last meeting or the one before. So use that, submit your work, look at what kind of amazing work you have. Also look at the education offers which you have at the EAO homepage. And with this, I would like to say again, thank you from the EAO, also from the EAO board, to Nicole, to our expert tonight. I would like to say thank you to all of you all around the world for listening, for asking questions. And I think this is a topic which remains in the back of your head, right? And you think about that, oh, what Nicole said, maybe I'm a little bit careful. And if we made that thinking in a lot of people, I think we did a lot. With this, I would like to say thank you, good night, goodbye. Ciao, ciao, all around the world. Nicole, again, thank you. Ciao, ciao to Sweden, and see you soon. Ciao.
Bye. Thank you so much, Stefan and everyone.